Okay, so today we'll study testicular tumors. Fine. For every tumor, I'll be going through the epidemiology of the tumor, risk factors of getting the tumor, clinical manifestation, how do you stage the tumor, diagnosis, treatment, precursor lesions, and the types of tumors. Okay. So the epidemiology of testicular tumors is that most of them are solid malignant tumor in young men between ages of 20 to 35 years, seminoma in the fourth decade. Okay. Now the risk factors of getting the tumor is cryptorchidism when there is problem with the descent of the testis. Contralateral testicular cancer is when you have testicular cancer in one of them, so there is a greater risk of having it on the other. Germ cell neoplasia in situ is a precursor lesion. Family history of testicular cancer, and then very importantly, Klinefelter syndrome. Fine. Then we do clinical manifestation, how the patient will present. They will have unilateral testicular enlargement. Neglected tumors will be spectacularly large. Okay. Primary testicular tumors undergoes regression. Patient is left with metastasis. How are testicular tumors staged? So, staging of testicular tumors. It is T and M staging. T is for tumor, N is for lymph node, and M is for metastasis. T is for germs. TPT is for precursor lesion. Already said. Germ cell neoplasia in situ. PT1 is without lymphovascular invasion in testis and epidermis. So the tumor is in the testis and the epidermis without lymphovascular invasion. In PT2, the tumor is in the testis and the epidermis with lymphovascular invasion and also sometimes seen in tunica vaginalis. PT3 is when it invades the spermatic cord. Okay. PT4 is when it invades the scrotum. Now we have to do the lymph nodes. If the size of the lymph node is less than 2 and it isn't more than less than 5 nodes, then it's PN1. PN2 is when the lymph node is between 2 to 5 centimeters and there is more than 5 nodes affected. Then it's PN1. PN3 is greater than 5 centimeters in size. M is basically for metastasis, and then you also check serum levels of LDH, HCG, and alpha fetoprotein. Okay. Now diagnosis, testicular mass during physical examination. Or how do you diagnose the testicular enlargement? So you have testicular mass during physical examination. I think ultrasound is the ultimate diagnostic tool used, and you also have to check the levels of alpha fetoprotein and human chorionic gonadotropin hormone. Okay, now we have to see the treatment. Treatment is mainly radical inguinal orchiectomy, in which you just remove the testis and you never do a transcortal biopsy because there are chances of spreading. Okay, fine. Now precursor lesion, this is the third time I'm saying germ cell neoplasia in situ, but it's for both seminomas and non-seminomas, and we'll come to that in a minute. Seminoma. Now the important thing to remember here is that if you ever find a germ cell neoplasia in situ during fertility test or something, the plan is to always directly remove it, because it increases the chance of having a testicular tumor. Now we're going to do the types of testicular tumors. Yay! So, testicular tumors are mainly of two types. First of all, primary and secondary. I forgot to write primary here, but it's fine. So, primary is then divided into germ cell tumors and non-germ cell tumors. Okay. Secondary is basically the ones that are coming from some other tumor metastasizing into the testis. But germ cell tumors are the most common ones. 95% of the testicular tumors are germ cell tumors. 5% of them are non-germ cell tumors, also called as Sex cord stromal tumors, it's another name. Okay, then you have, let's go to germ cell tumors. Germ cell tumors are mainly seminomas and non-seminomas. You can say spermatocytic is a type of seminoma, but I would say don't say it. Just mention it, I guess. But then you have embryonal teratoma, choriocarcinoma, yolk sac tumor, and mixed germ cell tumor. They all come under non-seminomas. Again, you have embryonal teratoma, choriocarcinoma, and yolk sac tumor, mixed germ cell tumor. They're all non-seminomas. Okay. Now, non-germ cell tumors, you have sex cord stromal tumors, also called as sex cord stromal tumors. You have Leydig cell tumor and Sertoli cell tumors. Okay. And in secondary tumors, which tumors mostly metastasize into the testis is lymphoma, prostate, and colon metastasis is mainly into the testis. Now we'll enter seminomas. Seminomas is the most common type of germ cell tumor. So 90% of germ cell tumors are seminomas. They have slow growth, malignant germ cell tumor, most common testicular germ cell tumor. Don't forget it's germ cell tumor, okay? Then it happens in mid 30s age, fine. There is painless enlargement of the testis. The precursor lesion is the same, okay? Macroscopically it will be uniform white coat section, okay? Microscopically it will look like a fried egg appearance, okay? Abundance of watery cytoplasm, fibrous septa, divided tumors into lobules. So basically the tumor will be divided into septas which will make lobules, fine. And you will also find lymphocytes and granulomatous cells present in them. Okay, now where do seminomas metastasize into? Like it's a primary tumor, so where does it metastasize to? Which lymph nodes? It's the iliac and the para-aortic lymph nodes. Okay, now remember the spermatic seminoma here. Spermatic seminoma. It is, I won't say it's a type, but it's nowhere actually. But I just felt like it was better classified here for some reason. Anyways, the spermatocytic seminoma is a rare. It has excellent prognosis. You will find three types of cells in spermatocytic seminoma. One is small, medium, large. Small ones look like lymphocytes, mediums look like spermatocytes, large ones look like, what do you mean look like? It has multiple nuclei. That's it. It looks like any cell that has multiple nuclei. Now, what was embryonal carcinoma? It was a part of non-seminoma. Okay, no Mars. Okay, so you have, it's also a malignant germ cell tumor. Pure embryonal carcinomas are rare. They are mainly found with some other things. It's never purely just embryonal carcinoma. So it's commonly found in the mixed form. It metastasizes very early and it's a very aggressive tumor, okay? It is painful, worse prognosis than seminoma. Microscopically, it is glandular and papillary. Macroscopically, it has a gray white with hemorrhage, necrosis, and cyst. Okay, now let's compare this with seminoma. It was slow growth malignant germ cell tumor, but this one was malignant germ cell tumor, mixed early metastasis and aggressive, so it's obviously fast growth. Okay, this was a painless enlargement. This one is an early, this one is painful. Okay. But they both are white. They both are white, and the difference is that embryonal carcinoma has hemorrhages. Okay, now we do yolk sac tumors. Yolk sac tumors. Okay, so yolk sac tumors, they are again malignant germ cell tumor. It mainly happens in infancy or early childhood. It increases serum alpha fetoprotein, very important. Very important. This is a VIP information. Then you have prepubertal, postpubertal. If someone gets yolk sac tumor before puberty, what happens? They are mostly pure or with a teratoma. Okay, good prognosis. Okay, post puberty, if they get it after puberty, then they have a mixed germ cell neoplasm and they increase alpha fetoprotein. Okay, so the most important thing here to remember is actually that microscopically you find something called Schiller duval body, which is a perivascular glomeruloid structure. It looks like glomerulus, okay, which is very important. Whenever you think of yolk sac tumor, you should always say it is mainly a childhood tumor. Okay, it increases alpha fetoprotein. Prepubertal has better prognosis, postpubertal has worse prognosis. Microscopically, you see Schiller duval body, and it has a what is Schiller duval body? It has a perivascular glomerulite structure. Looks like a glomerulus. Macroscopically, it is yellow, and you have a mucinous cut surface. Okay, now I'm tired of this color. Let's make it orange. Orange seems vibrant, and let's make this red for some reason. I don't know why. Anyways, now we do teratoma. Okay, now teratoma is again a type of seminoma, non-seminoma, sorry. It's a non-seminoma. It's a, sorry, germ cell tumor, frequently malignant, derived from two or more embryonic layers, multiple tissue types. It can have multiple types of tissue because it can originate from different layers of the embryonal tissue. So it can be either be cartilage, ciliated epithelium, liver cells, embryonic gut, striated muscle. Okay, now there are three types of teratomas, mainly mature, immature, and teratoma which has a malignant transformation. Okay, now mature teratomas will have mostly happen prepubertal. What did we say? It's the same as yolk sac. Prepubertal, benign, so better prognosis. Immature will happen post-pubertal, malignant, so worse prognosis. Teratoma with malignant transformation, that means it has a malignancy. The teratoma itself has a malignancy. So it can, this is an example of squamous cell carcinoma. Okay. Then the last one, no, not the second last one, you have the testicular choriocarcinoma. Okay, so it's again a malignant germ cell tumor, most aggressive. So what is the most aggressive tumor of the testicular tumors? Testicular choriocarcinoma. Okay, then you have early metastasis because it's very dangerous, it's aggressive. Early hematogenous metastasis to where? Lungs and the brain. Okay, contains what? Cytotrophoblast and syncytiotrophoblast. Okay, it is a multinucleated giant cell. Fine. Tumor markers are human chorionic gonadotrophin. Okay, it is highly sensitive to chemotherapy. It's highly sensitive to chemotherapy, which should mean that you have better prognosis. But let me check. Does it have better prognosis? You can answer in the comment section if you want. And then you have mixed germ cell tumors. Even with seminoma, it is considered a non-seminoma. So even if a non-seminoma tumor has a seminoma counterpart, you put it into non-seminoma and then it's under mixed germ cell tumors. Okay, hematogenous cut surface, solid areas, hemorrhage and necrosis. Prognosis depends on the least mature part. So prognosis is depending on the part of the tumor, because it's mixed, right? So there might be different parts in the tumor itself. So the ones that are least mature, that will decide the prognosis of the tumor. So I'm finishing testicular tumors here.